consultant with the Minnesota Department of Health, and I have no conflicts.
Thank you and welcome. Dr. Bell.
Beth Bell, clinical professor in the Department of Global Health at the University of Washington. I have no conflicts.
Good morning and welcome. Dr. Bernstein.
Good afternoon, all. My name is Hank Bernstein. I'm a professor of pediatrics at the Zucker School of Medicine at Hofstra Northwell, and I have no conflicts.
Welcome. Dr. Chen.
Wilbur Chen, professor of medicine at the University of Maryland School of Medicine, and I have no conflicts.
Thank you and welcome. Dr. Daly.
Matt Daly, senior investigator at Kaiser Permanente, Colorado, and associate professor at the University of Colorado School of Medicine. I have no conflicts. Thank you.
Thank you and welcome. Dr. Fry.
Thank you. This is Sharon Fry. I'm a professor of internal medicine at St. Louis University, and I'm a specialist in infectious diseases. Thank you.
Welcome. Dr. Cotton.
Camille Cotton. I'm the clinical director of transplant infectious disease and immunocompromised host infectious disease at Massachusetts General Hospital, and I'm an associate professor of medicine at Harvard Medical School.
Good afternoon and welcome. Dr. Lee.
Good morning. This is Grace Lee, associate CMO at Stanford Children's Health, professor of pediatrics at Stanford University School of Medicine, and I have no conflicts.
Good morning and welcome. Dr. Long.
Hi, this is Sarah Long. I'm professor of pediatrics at Drexel University College of Medicine in Philadelphia and a specialist in pediatric infectious diseases. I have no conflict.
Good afternoon and welcome. Ms. McNally.
Hello, Veronica McNally, president of the Franny Strong Foundation based in Michigan, and I have no conflicts.
Thank you and welcome. Dr. Paling.
Good afternoon. This is Kathy Paling. I am professor of pediatrics in epidemiology and prevention at Wake Forest School of Medicine. I have no conflicts.
Welcome. Thank you. Dr. Sanchez.
Welcome. This is Pablo Sanchez. I'm a professor of pediatrics at the Ohio State University School of Medicine and at Nationwide Children's Hospital, and I have no conflicts.
Thank you. Welcome. Dr. Talbot.
Hey, I want to say good morning. Good afternoon. This is Kit Talbot. I'm an associate professor of medicine and health policy at Vanderbilt University Medical Center, and my specialty is adult infectious diseases, and I have no conflicts.
Thank you. Welcome. Thank you all for being here. Let me go on to the ex officio representatives. As I call your organization, please state your name, and we'll begin with the Centers for Disease Control and Prevention.
Dr. Melinda Wharton is going to be covering for Dr. Nancy Messonnier today. Dr. Wharton, are you available yet?
Yes, I'm here. Thank you. Melinda Wharton from Centers for Disease Control and Prevention. Thanks.
Thank you, Dr. Wharton. Centers for Medicare and Medicaid Services.
Hi, this is Mary Beth Hans representing the Centers for Medicare and Medicaid Services.
Welcome. Food and Drug Administration.
Good afternoon, Doran Fink for the U.S. Food and Drug Administration Office of Vaccines.
Good afternoon and thank you. Health Resources and Services Administration.
Captain Dale Mishler, Division of Injury Compensation Program, standing in for Dr. Mary Regan.
Welcome, thank you. Indian Health Service.
Captain Thomas Weiser for Indian Health Service.
Thank you and welcome. National Institutes of Health.
Good afternoon, John Bago, National Institute of Allergy and Infectious Disease, NIH.
Thank you and welcome. Office of Infectious Disease and HIV/AIDS Policy.
Good afternoon, David Kim at YDP.
Welcome. Thank you. I will now turn to the liaison representatives. Again, I will call your institution and please state whether you're present. American Academy of Family Physicians.
Dr. Pamela Rockwell, AAFP, present.
Welcome. American Academy of Pediatrics.
Bonnie Maldonado, Professor of Global Health and Infectious Diseases, Chair, Committee on Infectious Diseases for the AAP.
Good morning and welcome. Dr. David Kimberlin.
David Kimberlin, AAP Red Book, present.
American Academy of Physician Assistants.
Marie-Michelle Léger, representing the American Academy of PAs. Good afternoon.
Welcome. American College Health Association.
Sharon McMullen, Cornell University, and Dr. Chavi Chai, University of North Carolina at Chapel Hill.
Thank you both. Welcome. American College of Nurse Midwives.
Carol Hayes, present.
Thank you. Welcome. American College of Obstetricians and Gynecologists.
Dr. Romero,
American
Linda Eckert. Oh, sorry. Linda Eckert's on the line, but she said she may or may not be able to respond.
Okay, thank you. I'll take that as a present. American College of Physicians.
Thank you, sir. Jason Goldsman, General Internal Medicine Affiliate Professor at Florida Atlantic University. Pleasure to be here.
Good afternoon. Pleasure to have you. Dr. Schumacher, American Geriatric Society. Forgive me.
Henchmaker here for AGS.
Thank you, sir. America's Health Insurance Plans.
Yeah, this is Bob Gluckman. I'm a General Internist, Chief Medical Officer for Providence Health Plans, representing AHIP. Thank you.
Thank you. Welcome. American Immunization Registry Association.
Good afternoon. Rebecca Coyles, representing ERA today.
Welcome. Thank you. American Medical Association.
I'm Dr. Sandra Freihofer, internal medicine physician and adjunct associate professor of medicine at Emory. I'm the liaison for the American Medical Association.
Welcome and thank you. American Nurses Association.
Ed Riddle, liaison for the ANA, present.
Thank you. Welcome. American Osteopathic Association. Excuse me.
Stephen Grauig, present. Good afternoon.
Good afternoon. Thank you. American Pharmacists Association.
This is Steve Foster. Good afternoon.
Good afternoon. Welcome. Association of Immunization Managers.
Hi, Molly Howell, North Dakota Department of Health and representing the Association of Immunization Managers.
Welcome and thank you. Association for Prevention, Teaching, and Research.
This is Dr. Paul McKinney, School of Public Health and Information Sciences, University of Louisville.
Welcome, thank you. Association of State and Territorial Health Officers, or officials, excuse me, forgive me.
Good afternoon. This is Nirav Shah, the director of the Maine Center for Disease Control and Prevention, here on behalf of ASTO.
Thank you very much. Welcome. Biotechnology Innovation Organization.
Good afternoon. Phyllis Arthur, present.
Thank you. Welcome. Council of State and Territorial Epidemiologists.
Hi, it's Dr. Christine Hahn, infectious disease physician and state epidemiologist for Idaho, representing CSTE.
Welcome and thank you. Canadian National Advisory Committee on Immunization. Canadian National Advisory Committee on Immunization. I'll come back to that. Infectious Diseases Society of America.
Jeff Duchin, Infectious Diseases Society of America. Good morning.
Good morning and welcome. International Society for Travel Medicine.
Elizabeth Barnett here for the ISTM.
Thank you and welcome. National Association of County and City Health Officials.
Hi, this is Matt Zahn representing NACHO. I'm present.
Thank you and welcome. National Association of Pediatric Nurse Practitioners.
Greetings. Greetings, this is Patsy Stinchfield, Children's Minnesota, representing NAPNAP.
Thank you and welcome. National Foundation for Infectious Diseases.
This is Dr. Bill Schaffner, Professor of Preventive Medicine and Infectious Diseases at Vanderbilt, on behalf of the NFID.
Welcome and thank you. National Medical Association.
Good afternoon. This is Pat Whitley Williams, Pediatric Infectious Disease, representing the NMA.
Thank you and welcome. Pediatric Infectious Diseases Society.
This is Sean O'Leary, representing Pediatric Infectious Diseases Society. Thank you.
Thank you and welcome. Pharmaceutical Research and Manufacturers of America.
Good afternoon. Corey Robertson, present.
Welcome, thank you. Society for Adolescent Health and Medicine.
Hi, it's Amy Middleman, representing SAM. Good
Hello,
afternoon.
thank you and welcome. Society for Healthcare Epidemiology of America. Welcome.
Reese, Christiana Care, representing Shay. Thank you.
Thank you. Welcome. Let me go back and see if Canadian National Advisory Committee on Immunization representative is on.
Dr. Romero,
Okay,
I believe they may be having a meeting at the same time or around now as well.
Thank you very much for letting us know. Thank you. The role is complete. Thank you very much. I will turn it over to
Dr. Romero.
Did I forget somebody? I'm sorry.
Sorry, this is Dr. Fry, a voting member of the ACIP. I believe I forgot to mention my conflict of interest.
Oh, please do.
My conflicts of interest. I am the St. Louis University principal investigator for the Moderna and Jansen trial here, and I think I should make that public knowledge. Thank you.
Yes, thank you very much. Are there any other voting members that feel they need to disclose something that they did not? All right, very good. So thank you all for being here. Let me turn this back over to Dr. Cohen, see if she has any opening words before I call the first speaker. And let me begin by saying that I'm gaveling in the session, which I didn't do because I don't have a gavel, but this meeting is in progress.
Thanks, Dr. Romero. I think we're all on board with that. So I do have a couple of slides. We're going to do a very shortened introductory session, but I do want to make a couple of key points about today's meeting, which was really just announced maybe 30 hours ago, and so there are a couple of special considerations. Next slide. So please, for all of those of you who are on the Zoom call, mute your lines until you're called on for discussion. When Dr. Romero opens the meeting, please virtually raise your hand. Dr. Romero will first take questions from the voting ACIP members and then ex officio and liaison representatives. Please disable your video in order for the Zoom call to work most efficiently, and except for if there is a vote this afternoon, ACIP voting members will turn on their video during the vote. A couple of additional points about meeting logistics today. This ACIP meeting was put together in the last 48 hours, and there may be some small errors on some of the slides. If we see those errors, we will correct those slides and put them up for final presentation after the meeting. I would ask that from the voting liaison and ex officio members, there is a single question at hand today, which is, do we have enough information, and what should we do with the current information we have available about the safety signal you will hear more about? We know that there are going to be lots of really important scientific questions, but we ask a couple of things. Please, that your comments or questions stay very focused on the information that was presented or help focus on the discussion and the question at hand today. If you have additional scientific or recommendations or suggestions, you are always welcome to share those with us. But there is a lot of work that's being done in the space around this issue, and we will present what we know today, and we anticipate having further discussions. But we really want to make sure that the discussion stays on focus so that we can either decide that ACIP comes to a conclusion and has a recommendation to make, or that they need additional time. Next slide. We did open up the docket for oral and written public comment. This was also it was open for a very short period of time because of the last minuteness of this meeting. But we do have a 20-minute open public comment session today. Those members, the individuals from the public, were randomly selected this morning to speak during the time slot. Additionally, there is an open docket available for written public comment, and That will stay open through Friday of this week. Next slide. As you already heard, a couple of the ACIP members do have disclosed potential perceived conflicts of interest related to research that they're doing with COVID-19 vaccines. We have issued limited conflict of interest waivers for any ACIP member, and those members may ask questions, but are asked to withhold from deliberation after the policy question is being deliberated, and will abstain from votes related to any COVID-19 vaccine. Next slide. And that is it today. We will first have Dr. Beth Bell is going to open us up today, Dr. Romero. We're going to have a presentation from the company and then take very focused questions, and then we're going to go through the rest of the presentations before discussion. Back over to you, Dr. Romero.
Thank you very much, Dr. Cohn. Let's begin with the chair of the ACIP working group for COVID vaccines, Dr. Beth Bell, to give an introduction. Dr. Bell, please.
Thank you very much, and good morning and good afternoon. Could I have the next slide, please? Before I introduce today's agenda, there's a couple of important issues, contextual issues, that we felt it was important for the committee be aware of in order to kind of best assimilate the information that's going to be presented. So I'm just going to cover a couple of areas, reviewing the adenovirus vector vaccines, describing the rare clot events seen after these vaccines, and a bit about the ACIP response, and then I'll go over today's agenda. Next, please. There are two adenovirus vector vaccines, the Jansen J&J vaccine and the Astrazeneca vaccine, as I'm sure most of you are aware. The Janssen vaccine is a single-dose vaccine. It uses human adenovirus 26 as its vector. An EUA was issued in the United States in February of 2021 of this year for the Janssen vaccine, and ACIP subsequently made recommendation. The EMA, which is the European Medicines Agency, has authorized the Janssen vaccine for Europe, but no doses have been delivered or administered in Europe. Now, the Astrazeneca vaccine is a two-dose vaccine. The vector is the chimp adenovirus. We are awaiting an EU application in the US, but it is approved in the UK and Europe, and as most of you are aware, has been in wide use in those areas and other parts of the world. Now, there have been concerns raised about rare clotting events seen after COVID-19 adenovirus vector vaccines. The clinical syndromes after both vaccines appear similar. You will hear more about this during the upcoming presentation. But the extent to which the cases seen after each of these adenovector virus vaccines represent exactly the same syndrome is not entirely clear at this time, and is something else that I'm sure will be discussed. Next, please. Now, there has been some activity with respect to the Astrazeneca vaccine, which I just wanted to review. Last week, the European Medicines Agency, the EMA Safety Committee, released a report that concluded that there was a strong association and probable causal link between the Astrazeneca vaccine and rare clotting events. There were press releases from both the European Union and the United Kingdom, and I've summarized them here. From the European Union, there have been 62 cases of CVST, which is central venous sinus thrombosis, and 24 cases of splanchnic vein thrombosis, all with thrombocytopenia. 18 of these cases were fatal. Most occurred in females younger than 60 years. They occurred primarily within 2 weeks of receipt of the AstraZeneca vaccine. And in the EU, unfortunately, because of different ways that the vaccine is used in each country, the EU was not able to exclude age and gender as risk factors. They just don't have the denominators, I imagine. From the United Kingdom, they reported 79 cases of thrombosis and thrombocytopenia. 19 were fatal. Among these, there were 34 cases of CVST with 14 fatalities and 35 cases of other clotting disorders with 5 fatalities. 51 cases were female and 28 were male. This is on the context of a denominator of 20.2 million doses given in the UK. The press release estimated a risk of about 4 per million persons, with the comment that there was a slightly higher incidence in younger age groups. Next, please. There very recently were 2 reports in the New England Journal of low platelets, that is thrombocytopenia and blood clot thrombosis, after the AstraZeneca vaccine in Europe. These 2 cases came from, I believe this is a typographical error, from Germany and Austria and Norway. Many of these cases had platelet activating antibodies directed against platelet factor 4, PF4, which is a clue to the possible mechanism here. And the authors proposed a syndrome entitled vaccine-induced immune thrombotic thrombocytopenia. Next, please. I just wanted to take a moment to review central venous sinus thrombosis, CVST, since this is one of the more predominant syndromes or conditions that have been identified. This involves thrombosis within large vessels that are draining blood from the brain. And you can see in this figure here, which may or may not be readable, the various parts of the circulation. It mostly occurs among people 20 to 50 years of age, mostly female. Risks include pregnancy and other identified risks for coagulation, such as oral contraceptives. Symptoms typically include headache, nausea, vomiting, and other neurologic symptoms, and the presentation can be acute or more chronic. And I'll just make a point that this is kind of an overall description of CVST, not specifically CVST with thrombocytopenia, which is what has been seen in the current situation. Next, please. So what has happened as a result of these findings in Europe? The EMA's Pharmacovigilance Risk Assessment Committee doesn't make vaccine policy for the EU. Each country makes its own policy. But many countries have made new policy and have adopted age-based recommendations. In the UK, on April 7th, the recommendation was made to use the AstraZeneca vaccine in adults 30 years of age and older. In Australia, adults 50 years of age and older. And in other European countries, a range of from 55 to 70 years of age, depending on the country. Next, please. Now, I just want to say a little bit about the Jansen J&J COVID-19 vaccine, which of course is the focus of our meeting today. As I mentioned, it received an EUA from FDA in February, and ACIP made recommendations. On April 13th, CDC and FDA issued a joint statement on the J&J COVID-19 vaccine. Made the following points: that as of the day before, that more than 6.8 million doses of the vaccine had been administered in the United States. The CDC and FDA were reviewing data involving 6 cases of CVST in combination with low platelets reported among recipients of the J&J vaccine in the United States. And the statement said that CDC will convene a meeting of the ACIP on Wednesday to further review these cases and assess their potential significance, which is what we're doing today. And that until the process is complete, that there's a recommendation to pause the use of the vaccine out of an abundance of caution. Next, please. One of the other things that came out of this press release, a point that was made in the press release, that one of the important reasons for the pause was to allow time to provide information to clinicians and to the public about specifics around, and unique aspects of diagnosis and treatment and clinical signs and symptoms to monitor. And the first step in that process occurred with the issuance of a HAN, a Health Alert Network release on April 13th, which provided recommendations for clinicians on diagnosis and treatment, recommendations for public health on how to report cases through VAERS, the Vaccine Adverse Event Reporting System, and recommendations for the public on clinical signs and symptoms to monitor and when to seek medical attention. You'll be hearing much more about the details and specifics of HAN later on during one of the other presentations today. Next, please. Here's a few of those details for clinicians for diagnosis and treatment to evaluate patients with a screening P-F4 ELISA that would be performed for autoimmune heparin-induced thrombocytopenia, consulting a hematologist, and importantly, don't treat with heparin unless this test is negative. Encouraging reporting through VAERS, and for the public to know to contact a healthcare provider or seek medical care if you develop a severe headache, abdominal pain, leg pain, or shortness of breath within 3 weeks of vaccination with the J&J COVID-19 vaccine. Next, please. So the ACIP response this week so far has included a meeting on Monday of the Vaccine Safety Technical Advisory Group, and you will hear a report of the outcome of that meeting and a summary shortly. Yesterday, there was a meeting of the ACIP COVID-19 Vaccines Work Group. Again, you'll be hearing about this. And obviously today, we're having an emergency ACIP meeting with the purpose of considering the implications of reported cases of thrombosis and thrombocytopenia after the Jansen J&J vaccine. Next, please. So the agenda today will include an overview of the safety of Janssen's COVID-19 vaccine by Dr. Aaron Mari from Janssen Pharmaceuticals of Johnson & Johnson. Presentation on cerebral venous sinus thrombosis with thrombocytopenia after COVID-19 vaccines from VAERS by Dr. Tom Shimabukuro. The assessment of the vaccine safety committee from Dr. Grace Lee, who is the VAST chair. The work group interpretation from Dr. Sarah Oliver, who's the CDC lead on the work group. Public comment, discussion, and then potentially a vote with updated interim recommendations if appropriate at that time. Next. I'm putting here again our list of the work group members, ex officio members, liaisons, and consultants. Next, please. And all of the CDC participants, and as always, I'm very grateful to everyone for their participation and contributions in this process. Next, please. Thank you very much, and I turn the floor back to Dr. Romero.
Thank you, Dr. Bell, for that introduction. We'll move forward then with the presentation by Dr. Aaron Marie from Janssen Pharmaceutical Companies, an overview of safety with Janssen's COVID-19 vaccine, Ad26-CoV-2S. Dr. Marie.
Thank you, Dr. Romero. Can you hear me okay?
Yes, I can. Go ahead.
Thank you. My name is Aaron Marie. I'm the Chief Medical Officer for Jansen and head of our Global Medical Safety Organization. And it's a great pleasure for me and my colleagues to be with you this afternoon to present to the committee. Next slide, please. So in the next 15 slides, which I'm going to step through reasonably quickly in order to respect the committee's time and ensure you have time for questions and answers, I'd like to take you through the relevant Jansen clinical and post-authorization data on the subject of thrombosis, particularly CVST with thrombocytopenia, and also describe our background epidemiological data set in the context of our overall evaluation. Next slide, please. Firstly, I'd like to emphasize that the safety and the well-being of the people who use our products is the #1 priority for our company. While causality has not been fully established between these very rare events and our vaccine, we recognize these events could represent an important potential risk with the Janssen vaccine. We're in the process of updating our company core data sheet and working with health authorities to update our labeling appropriately. Johnson & Johnson will continue to monitor this potential risk, and we are committed to efforts to ensure vaccinee and healthcare professional awareness of the important signs and symptoms of this event, as well as appropriate diagnosis and management. Next slide, please. I'd now like to take the committee members through a review of the data. I'll start with the clinical trial data, and as the committee is aware, we have 2 pivotal phase 3 clinical trials in our program. Study 3001 is the single-dose phase 3 trial, and I'll present here on the slide the adverse event data with respect to venous thrombosis events. And the subsequent slide will be our study 3009, which is still ongoing as well. This study remains blinded, but I will also present to you the venous thrombosis events. So study 3001, we have vaccinated 43,783 participants. And I list along the left column here, row by row, the DVTs, PEs, cerebral venous sinus thromboses, venous thrombosis, and embolism venous terms. There are 4 columns. The first 2 columns are the adenoviral vaccine, the placebo, and the number of cases up to 28 days after vaccination. And the third and fourth columns are the total number of cases to date. So as the committee will see, in the 28 days after vaccination, we have collected 4 DVTs in the active arm of 3001 and 2 cases in placebo. We have 2 cases of PE, 1 case of placebo. We collected 1 CVST and 1 venous thrombosis of a limb, both of those in the active arm. Total number of cases include 11 DVTs in the active arm, 3 in placebo, 8 pulmonary emboli in the active arm, 4 in placebo, 1 CVST already mentioned in the active arm, 1 in placebo after 28 days, and then the venous thrombosis of the limb and the venous and a 1 venous embolus. Next slide, please. In study 3009, which is the ongoing phase 3 2-dose pivotal trial, we have vaccinated 28,277 participants. This study remains blinded, and the data are presented as blinded. In this study, we have had 1 pulmonary embolus event up to 28 days. We have had 2 DVTs at all time points, and 4 PEs also beyond 28 days. Again, this study remains blinded. Next slide, please. There is also an ongoing study, a large open label study in South African healthcare professionals. This has enrolled currently 2,000 272,438 participants of a total anticipated 500,000 participants. And I'm presenting the safety data to you here as of the 9th of April. As of that date, we have had no reports of CVST. We have had one case of pulmonary embolism. There has been no information on platelet or COVID status with this case. We have had one case of CVA in a 38-year-old female, 8 days after vaccination, and are actively seeking additional information on this case through the PI. And we have had one report of retinal vein thrombosis in a 68-year-old diabetic, and the platelet count for this case was reported as normal. Next slide, please. I'd now like to take the committee through all known cases of CVST and all known cases of thrombosis with thrombocytopenia with the Jansen COVID vaccine to date. This is the slide derived from the CDC public website showing the number of vaccinations to date administered in the United States with the Jansen COVID-19 vaccine. And as of this morning, I believe that number is now 7.2 million doses administered. And as of 14th of April, Janssen is aware of 6 post-authorization cases of cerebral venous sinus thrombus, 4 of 6 with low platelets, and 2 unknown within these individuals vaccinated. Next slide, please. This is the table as described of all known cases of thrombosis with thrombocytopenia with the Jansen COVID-19 vaccine. The first 2 rows are the cases already described within the phase 3 clinical trial program. The following rows are the post-authorization cases. In study 3001, the first row, the case was of a 25-year-old male on vaccine. The report was of a CVST with hemorrhage. It was noted that the subject had stenosis of his transverse sinus, and there was a suspected upper respiratory tract infection. The platelet count nadir was reported at 64,000. We have recently retrospectively determined that his antiplatelet factor 4 antibodies at baseline were negative, and post-vaccination, I believe around day 28, but may be corrected, were positive. His COVID status was negative. Time to onset was 8 days after vaccination, and this gentleman was treated with heparin, TPA, received platelets, had 2 balloon angioplasties and thrombectomies due to the discovery of a venous sinus stenosis, and he has recovered and has been discharged from hospital. The second row from study 3001 is the participant who has recovered from a CVST. She was a 24-year-old female, but was on placebo. She had a normal antiplatelet factor 4 antibody test post-vaccination, post-incident. Her COVID status is negative. The time to onset was greater than 50 days after vaccination. I'd next like to describe 7 post-authorization cases, including 1 of deep venous thrombosis. The committee may be aware that cases in the post-authorization phase come to Janssen primarily from 2 sources. The first 3 cases described and the final case come through the VAERS vaccine adverse event reporting system, the joint CDC FDA reporting system. We gain access to these reports when they're refreshed every Friday. There is a slight lag in reporting to us, and understandably, for privacy reasons, there is significant redaction of some of the data fields, and it is not possible for us to follow up for further information or evaluation beyond what is presented to us in the preliminary report. We can attempt to do so through freedom of information applications, and FDA has been very supportive in helping us to try to expedite these requests. The other cases come to us directly, either through our call center or through our website or email. And these clearly allow us the opportunity to go back and get further information and are therefore a richer data set. So after I have described the post-authorization cases to the committee, I will quickly step through 3 cases that contain significant details of interest to this discussion. The first case in the post-authorization phase, the first row in blue after the green row, was a 45-year-old female. She presented CVST with hemorrhage. No risk factors were described in the report. The report notes the term thrombocytopenia. COVID status was unknown. Time to onset after vaccination was reported at 11 days. Treatment was not described, and this patient died. The second case also came through VAERS. It was a 38-year-old female. She presented with CVST, risk factors unknown, platelet count unknown, COVID status was not described in the report. Time to onset was 10 to 14 days after vaccination. She was treated with heparin, and at this time, she is described in the report as not recovered. The third case was a 59-year-old female. She presented with extensive deep venous thromboses on her left side. She had known coronary artery disease. Her platelet count nadir was reported at 15,000. COVID status unknown. Time to onset after vaccination was 7 days. A vena cava filter was inserted in her inferior vena cava, and she also underwent thrombectomy. The day after the procedure to place the inferior vena cava, she was reported to have significant thromboses on her right side, significant DVTs on her right side, and it was questioned as to whether or not this was secondary to the intervention or partially precipitated by the intervention through her right side to place the inferior vena cava filter. At this time in the report, her status is not recovered. The next case is reported as a Jansen serious adverse event report, came to us from Nevada. It was an 18-year-old female. She presented as a CVST with hemorrhage, risk factors unknown. Platelet count nadir was 16,000. The COVID status was unknown. Time to onset after vaccination was 14 days. She was initially treated on heparin and then switched to what is reported as treatment according to the British guidelines, which I take to refer to the guidance announced by the expert hematology panel affiliated with the British Society of Hematology, and she then also underwent a thrombectomy. At this time, her status is described as not recovered. The next case was reported directly again to Jansen. This was reported through pre-publication by the New England Journal via an editor notification directly to the company, and the case is in Nebraska. This is a 48-year-old female. She was reported as presenting with TTP, splanchnic vein thrombosis, CVST. She was initially given heparin, and then additional hepatic and splanchnic vein thrombosis was reported. Risk factors unknown. Her platelet count nadir was reported at 13,000. She was also reported to have a high D-dimer and a positive antiplatelet factor 4 antibody test. COVID status was reported as negative. Time to onset 14 days after vaccination. She was treated with heparin at first, and then after the antiplatelet factor 4 antibody test resulted, she was switched to argabatran and then also given IVIG. At this time, her status in the report is not recovered. The next case was also reported to Jansen directly, comes from New Jersey and Pennsylvania. The case is a 26-year-old female who presented with CVST, PE, portal vein thrombosis. Risk factors described are obesity. Platelet count was 120,000. She also had a high D-dimer and a positive anti-platelet factor 4 assay. Her COVID status was negative. Time to onset after vaccination was 7 days. She was treated with heparin and then with IVIG and has been discharged from hospital. The final case was notified to us through VAERS, has very limited detail on the company side. It refers to a 28-year-old female, and details are pending under a Freedom of Information application via FDA to CDC. I'd now like to take you through 3 of these cases which have more detail. The first case I'd like to go to is the New England Journal case, the pre-publication case that I mentioned from the University of Nebraska, which we received on Thursday, the 8th of April. This 48-year-old woman was described as having an unremarkable past medical history, presented to ER after 3 days of malaise and abdominal pain. The initial evaluation describes mild anemia and severe thrombocytopenia with a platelet count of 13,000. A blood smear confirmed marked reduction in platelet count with occasional schistocytes. She had hypofibrinogenemia, a prolonged APTT, and markedly elevated D-dimer, and was noted to have extensive splanchnic vein thrombosis on CT. She was transferred then to the reporting institution with further evaluation and progression noted of the thrombosis on heparin. She had a negative PCR test for SARS-CoV-2, a head CT for new onset headaches reported in her secondary hospital, showed cerebral venous sinus thrombosis. Thrombosis progressed with hemorrhagic stroke despite treatment with heparin. She underwent repeat CT angiography, which showed new thrombus involving the right hepatic and splenic veins. Further inquiry revealed the patient received our vaccine 14 days before symptom onset. The report describes evidence and then management of possible immune thrombotic thrombocytopenia, ITT. She had positive antiplatelet factor 4/heparin antibodies by ELISA. Her latex enhanced ELISA assay, immune assay, was negative. Her heparin was switched in the second hospital to argabatran. She was given IVIG 1 gram per kilogram of body weight for 2 days. Her platelet count was reported to have increased from 30,000 to 145,000 over 5 days, and she remains critically ill as of the last report. The next case, also reported directly to Jansen, and subsequently further details received on a phone call contact with a physician on Monday, the 12th of April, is of a 26-year-old woman who is described as overweight but active. I believe she's a gym instructor with no history of clotting disorder and on no medication. She initially presented to the emergency room with severe headache approximately 1 week following vaccination. She has been discharged home from the ER. She was then discharged home from the ER with paracetamol and Benadryl. However, her headache persisted. She was subsequently admitted to hospital another week later with abdominal pain and a rapid heart rate. COVID-19 infection was ruled out, although we have no details of the exact test. Laboratory evaluation revealed thrombocytopenia with a platelet count nadir at 120,000, elevated D-dimer, and normal fibrinogen described, but the level exact level not known. The diagnostic scan showed CVST, portal vein thrombosis, and pulmonary embolus. She was initially treated with heparin, and this was described as having been switched to IVIG after the clinical team became aware of a positive anti-PF4 antibody test result. Her platelet count reportedly started to increase before the IVIG was commenced. This patient has been discharged home on oral anticoagulants after a period of 1 to 1.5 weeks in hospital. Next slide, please. This case is from our clinical trial program, study 3001, and is of a 25-year-old male, healthy, active male who was vaccinated on September 21, 2020. 8 days after vaccination, the subject began to feel progressively unwell, describes fatigue, faintness, nausea, headache, for which he took NSAIDs. 11 days post-vaccination, that's 3 days later, he describes continued fatigue, weakness and nausea, and also abdominal pain and headache. A COVID-19 swab taken by the PI on that date was negative. He was then hospitalized 19 days post-vaccination after a visual disturbance and collapsing. This was on October 9th, 2020. Laboratory evaluation, the platelet count was reported at 64,000, PT 17.7, INR 1.46, fibrinogen 154, white blood count 12.4, hemoglobin 12.7, hematocrit 36.1. He underwent CT, MRI, and venogram, and his diagnosis was of a cerebral venous sinus thrombus and secondary cerebral hemorrhage. The gentleman underwent repeated cerebral vascular sinus thrombectomy and balloon venoplasty due to reocclusion and treatment for a tight stenosis in his venous sinus. He was also treated with low molecular weight heparin and IV TPA. Extensive hematology and infectious disease laboratory evaluations showed inconclusive results. Please excuse the typo, that should read inconclusive results. The patient was discharged on treatment with apixaban. Last week, stored serum tested positive for anti-PF4 antibodies for the post-vaccination phase, and the baseline laboratory anti-PF4 antibody test was negative. This gentleman recovered after repeat thrombectomy and balloon angioplasty. He was described as having severe epiglottitis while in hospital, and his discharge meds included apixaban. I would next like to briefly invite my colleague, Dr. Courtney Davis, to describe the epidemiological analysis that we have conducted to assist this investigation. Thank you.
Thank you, Dr. Marie. I'm happy to join you today. I'm Courtney Davis. I'm an epidemiologist from our global epidemiology group at Jansen. And we conducted a published literature search. Actually, the articles that were retrieved included studies and populations from the US and EU, as well as from the Middle East and Asia Pacific. We also conducted an internal analysis of large healthcare databases. And what you'll see on the next slide are results from a meta-analysis across 4 large US healthcare claims databases and 1 US electronic health record database. And that study design was to generate background incidence rates of CVST. We used the study period of 2017 to 2019 to generate the incidence of the outcome CVST. The methods used for that analysis are similar to those that were used in a multinational network cohort study of 15 different adverse events of special interest. And those, the results of that larger network study have been shared with FDA and EMA and are published on a preprint server, and a manuscript of those AESI background rates are also under review. You could go to the next slide. So these are kind of hard to read. I apologize, it's a lot of numbers, but did wanted to be transparent in showing estimates from the published literature. Those are in the bottom rows of the table, and also those from database analyses conducted by Jansen and also by the Access group in Europe. So I will start with the bottom, actually, because that's the published literature, and that may be what folks are more familiar with. And those are shown for overall adults, the background incidence rate. These are shown per 100,000 person years. And those range from 0.2 to 0.5 or 2 to 5 per million. In the older studies to higher rates, upwards of about 15 per million in the more recent studies that come from the bottom two references there. The results of our claims database are the first row, and those are not published yet. As I mentioned, those were just generated. And those are by age and sex, and we thought it was important to display that for you, since there is more attention as a potential higher risk among younger women. And what you can see displayed there are, in fact, higher rates observed from this claims database analysis, the highest being observed in the women ages 18 to 34, which shows 2.6 per 100,000 or 26 per million, and an overall rate for ages 18 to 85 in women of 17 per million or in men of 12 per million. That gives you an understanding of the range of the estimates from more contemporary claims database. But I would like to point out limitations of the claims data include there is no validation of the outcome of CVST. And that is, we did the best we could with the diagnoses which come from hospitalized events. And finally, I would just mention that right now we're working on stratified analysis of CVST incidence by thrombocytopenia, and that is underway right now. I'll hand it back over to you, Dr. Marie.
Thank you, Courtney. Next slide, please. And Dr. Davis's presentation reminded me to inform the committee that while we don't have ethnicity reported in all of the post-authorization reports, we do know that the single case of CVST in the active arm in our 3001 study was in a white male, the 25-year-old. And we do have the data on 2 of the post-market reports indicating that they were 2 white females, but the others are not, it's not described in those case reports. Thank you for the reminder, Courtney. And finally, the Jansen is conducting an intensive ongoing review of internal and publicly available data, including but not limited to evolving literature on the relationship between COVID and thrombocytopenic and thrombotic events. We're interrogating case reports of association between thromboembolic events, including CVST with ITP and TTP, and also searching the US vaccine adverse event reporting system data on thrombocytopenic and thrombotic events and other adverse events of special interest for all available vaccines, and also the European Eudravigilance adverse event data set. So in conclusion, Chairperson, I'd like to reiterate that based on the current data, Janssen believes the overall benefit risk profile for our vaccine is positive across the population for which it's authorized. We strongly support ensuring vaccinee awareness of the signs and symptoms of this very rare event, as well as the recommendations to ensure the correct diagnosis, treatment, and reporting by healthcare professionals. Thank you.
Dr. Marie, thank you very much for that detailed and comprehensive review of what is known. We're going to open it up to questions now from the voting members initially, and then liaisons. At the risk of revealing my knowledge lacunae, can you tell me what, if any, is the significance of the latex enhanced negative assay on the first case that you presented, or for PF1/4 antiplatelet factor antibodies?
So Dr. Romero, if there are hematologists present, they will be more expert than I. However, it has been represented to me that for the PF4 test, it's important to use the ELISA test, but some of the other assays may not be as sensitive as the ELISA test for anti-PF4. So in the case where both were reported to us, we represented both.
Very good. Thank you for that clarification. Let me see if I can turn to my list of participants and questions. Are there any questions? You can raise your hand, please. Dr. Bernstein.
Thank you for that presentation. Obviously, this is unique circumstances. I just had a couple of questions just for clarification. One of the patients, a number of the patients were described as having recovered, and one of the patients was described as discharged from the hospital. Is that considered recovered, or what is recovered mean? They're back to normal, or they're still being treated and monitored?
Thank you for your question, Dr. Bernstein. The reports, which are known as CIOMS reports that are reported to VAERS, have a number of fields, including a field for status with a limited number of options available. So some of what is represented is somewhat clunky form terminology due to the limited options available.
Thank you. And then on slide 15, with the background incident rates of CVST, were those cases, we do not know about their platelet counts. So these are the background incidence rates of CVST without thrombocytopenia, correct?
This
Let
is
me ask
Dr.
Dr. Davis.
Thank you. This is all CVST, and it is not stratified in this analysis by thrombocytopenia status. So that's what we're working on at the moment, is to split those and to be able to generate an incidence rate for CVST with concurrent thrombocytopenia or low platelet counts versus the cases that do not. Right now, this is just any CVST.
Thank you.
Dr. Sanchez, please.
Thank you, Jose. I have and thank you for the presentation. Certainly concerning. I had a few questions. First of all, did any of the women, were they had a recent pregnancy or were any postpartum? Second of all, did any have a history of like preeclampsia in a previous, in some pregnancy? And then if you have any information on other medications such as oral contraceptives that some of these women may have been receiving.
Thank you, Dr. Sanchez. We did scan all reports and send questions back to those for whom we had identifiable reporters asking those. And as per the presentation, we don't have reports of recent pregnancy or recent or the subject being in the postpartum period or having suffered preeclampsia. I don't believe any of the participants, other than the one woman, the 24-year-old female in the placebo arm in our clinical study who had a CVST at beyond 50 days, she was on OCP, but it is not described to the best of my recollection for any of the cases post-vaccination.
Dr. Romero, I just want to also add to the committee, let the committee know that the next presentation by Dr. Shimabukuro will go through the VAERS reports with some specificity, and we'll share any information we have about those cases.
Thank you for that information, Dr. Cohn. Dr. Sanchez or Dr. Marie, do you have any more to add?
No,
very good. Very good. Sorry, wanted to make sure I didn't cut anybody off. Dr. Paling, please.
Hi, thank you very much for this presentation. I wanted, when I was listening to the presentation, I believe the one case from New Jersey, Pennsylvania that was directly reported had CVST with pulmonary embolism. I wanted to ask, were there any cases of pulmonary embolism without CVST that you guys are aware of? And are you looking for those?
Thank you, Dr. Paling, for the question. We have had cases of pulmonary embolus, but none reported in the context beyond what's been described today, none reported with concomitant thrombocytopenia.
Thank you.
How many
Dr. Paling, continue.
How many cases have been reported and the time frame?
Let me just pull up the table for you here. Dr. Nettles, could you pull up table 18? And Dr. Chang, remind me if there are other tables. So this is while Dr. Nettles is pulling up the table, we have interrogated the VAERS database, looking for thrombocytopenic, thromboembolic, and hemorrhagic events that have been observed after vaccination. And we have a report as of the 9th of April. We've had 55 reports of thromboembolism. We've had 4 reports, the third row down, of thromboembolism with thrombocytopenia. We've had 2 cases of CVST, and then other adverse events specifically described in the rows below. And that's at an exposure of 4.9 million doses administered.
Dr. Paling, any other questions? Dr. Marie, please forgive me. Since I cannot see you, I'm not sure if you're done with your answers.
Thank you. Yes, indeed. In addition, in the phase 3 program, which is on slide 19, the summary of total venous thrombosis events, up to 28 days, in the first column there, you'll see 2 PEs in the active arm and 2 balanced with 2 in placebo. So that, again, just reiterating in a more comprehensive slide, the venous thrombosis events from our 43,000 person study.
Dr. Paling, anything else to add or questions?
I do not. Thank you.
Thank you. Dr. Alt, please go forward.
I want to just ask a quick follow-up question. You had mentioned the Ebola vaccine and the RSV vaccine that used the same vector, and there were no cases of this in those trials. Were there any thrombotic events or thrombocytopenic events, especially in imbalance? In the Ebola vaccine trial, I believe you had a fair number of pregnant and postpartum women, so you definitely had people that had risk factors enrolled in those trials.
Thank you, Dr. Alt, for the question. I'd like to ask my colleague, Dr. Dwogi, from our clinical team to respond to that. We certainly have had no CVST events, as you mentioned, but I'll let Dr. Dwogi respond to your question more broadly.
So I hope you can hear me well. Makaya Dwogi, Head of Clinical Development and Medical Affairs for Vaccines. So it's true we have not seen CVSTs in any of our programs. Ebola and RSV are probably the biggest ones. We have had some cases of DVT and PE. None to our knowledge are associated with thrombocytopenia, and there were clear risk factors, so OCPUs that were considered attributable to the events.
Thank you.
And just if there's just one case of immune thrombocytopenia that we had in the RSV program. We don't know if there is anti-PS4 antibody. I mean, this is relatively new, and this was a case from maybe a year or so ago. We will go back and look to see if there are any stored samples to be able to test. We don't have that information, but that's the only case that we have. And the denominator is for what I'm talking about is about 200,000 people or more that have received at least one dose of an adeno-based vaccine.
Thank you. Dr. Long, please.
Yes, it's a question probably for Dr. Davis about, I didn't quite understand how the epidemiologic studies were done related to the healthcare people that you had under surveillance. I know they had to be in the system for a year, and then did you follow them for a year? And are these basically numbers of cases expected in 100,000 people over 1 year? Because my question would be then, did you do any other sort of tricky analysis? Because the clustering of these cases around the vaccine obviously is very provocative and kind of compelling. So did you estimate the number of cases if you took some random event like the anniversary of the person's birthday and asked in 1 month after some random event, what then would be the number of cases per 100,000 people in 1 month's time?
Thank you for that question, Dr. Long. I'll try to describe the cohort design, and then I'll try to answer your specific question. So yes, it's a kind of classic incidence cohort design where the person had to be observed in the database for a year prior to prove that they didn't have a CVST in their history. So it is looking for new diagnoses of CVST in a 1-year follow-up period. So I hope that answers the first part. The second part, though, your question around picking a random date and then looking out 1 month. I mean, we did look up to a year, and I think if you wanted to generate a person month estimate, I don't have a specific way to answer your question. I don't think.
Maybe the CDC people will address this a little bit, but I'm tempted to want to divide by 12 for the background incidence in a month's time, unless there's some other reason for these other sporadic cases to be clustered, and which would change very much what the dynamic was of, was this in the expected range if they occurred within a month or even 2 months of vaccination. Thank you.
Yeah, when we, maybe I could also add, when we convert this to an expected number, when we do the formal observed to expected analysis, that is what happens. So we do convert it into, if we are generating it for a 28-day risk period, which we would be doing, then we do divide by 12 in order to create the expected number. And that would also be using the age and sex-specific rates.
I see. So in the women of 18 to 34-year age group, where it might be 26 per million, it might actually be 2 per million expected. Right. In a month's time, 28-day time.
We convert it based on, and we apply it to the actual exposure distribution for the vaccinated when we go through that exercise. But to answer your question, I think simplistically, yes, if we want to use these rates to convert them to a expected 28-day observed, expected, yes, you would divide by 12.
And Dr. Long, I do think that some of this will be brought out in future discussions.
Thanks very much. Great, thank you.
Ms. McNally, please.
Thank you. Dr. Murray, I'm the consumer representative, and I am just trying to understand the reporting process on safety events. So can you help me understand how Janssen makes the FDA and CDC aware of serious adverse events that are reported directly to Janssen? And then to what extent Janssen shares the details of those cases with FDA and CDC?
Thank you very much for the question. When patients when subjects are vaccinated in our clinical trial, there is an expedited serious adverse event reporting process via clinical trial process through to the health authorities, Mrs. McNally. In the post-authorization phase, when the vaccine is being given to the public, there are a number of ways in which patient experiences or adverse events can be reported. And when patients receive the vaccine, they're often given a fact sheet, and there is information presented to them on reporting to the FDA, CDC, via VAERS. There is a vSafe program for which I myself signed up, which then sends daily or regular text messages asking for the experience in the post-authorization first few weeks, which then is sent also to theirs. And if any reports of adverse events come directly to the company, we have an expedited reporting process whereby we process those cases and send them immediately to the FDA, to the European Health Authority, and to other global health authorities. So there is a continuing, sustained, rapid reporting of events between the companies and the health authorities in the various jurisdictions. The health authorities then do, for cases of particular interest to them, reach out to the company and also with requests for further information, and we support those again to the deadlines required by the health authorities.
Thank you very much for answering those questions, and your team for answering the questions. We're going to move on to the next presentation now by Dr. Shimabukuro from the CDC regarding the update